What are the findings in this ECG and possible explanations? Most of the beats show a large pacing spike just before the QRS complex, indicating a ventricular paced beat, possibly with unipolar pacing mode. In unipolar pacing, the lead tip in the right ventricle acts as the negative electrode, cathodal pacing, and the pacemaker can acts as the positive electrode. This causes a long electrical circuit between the two so that surface ECG detects a large pacing spike. In bipolar pacing, the lead tip is negative and a proximal ring electrode is positive. So the pacing circuit is completed within the heart and is very short. Hence, the surface ECG detects a small pacing spike. But in modern day monitors, switching on the pacemaker detection algorithm can also enlarge the displayed spikes. Ventricular rate in this ECG is about 50 per minute, indicating a low programmed pacing rate. Every third complex starting from the first beat seen in the lead 2 rhythm strip is a spontaneous beat with a PR interval of 160 milliseconds. This would indicate that the indication for pacing would have been sinus node dysfunction, as no dissociated P waves are seen. Dissociated P waves would have suggested complete heart block as the reason for ventricular pacing. QRS complexes have left bundle branch block morphology, negative in V2, V3 and positive in 1 AVL. This is seen with right ventricular pacing. Paced complexes are negative in inferior leads. This means that the ventricular activation is proceeding from below upwards as seen with right ventricular apical pacing. QR complex with T inversion in the sinus beat in AVL indicates lateral wall infarction. Chord ST segment elevation along with T inversion is seen in paced beats in anterolateral leads, suggesting anterior wall myocardial infarction. The QRS complex of sinus beats show QRS width of 120 milliseconds and left axis deviation suggestive of left anterior hemiblock LAHB. QRS width of paced beats is 200 milliseconds, indicating significant myocardial damage. Sgarbossa criteria, originally described for diagnosis of myocardial infarction in left bundle branch block, has been later applied for right ventricular pacing. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video.